The simplest method of inducing anesthesia is by dropping ether onto a mask through which the patient inhales the vapor. Although better results can be obtained by more elaborate methods, ether is relatively safe, and as comparatively few accessories are necessary, it's valuable as a standby when other equipment is lacking. It's one of the most difficult anesthetics to give really well. First, we'll show you how it should be done. Here is the apparatus you'll need. A medicine bottle for the ether, which is fitted with a Bellamy Gardner dropper. If you haven't a medicine bottle and dropper, an ordinary stock bottle will do, and you can improvise a dropper from the cork. Cut 2 grooves, one on each side of it. Put a gauze wick in one groove and ram the cork in firmly. This will give you a steady flow. The mask is a schimmelbush or other standard design. It has a spring band to hold the gauze in position. The gauze has been folded into 10 or 12 thicknesses. It's clipped into position over the mask. You'll also need a piece of gamgee, 8 inches by 10, with a 4-inch slit in the center. A piece of oiled silk or jaconet with a small hole in the middle. You'll want a tube of sterile Vaseline to lubricate the airways. This is a Waters metal airway, which is curved to fit the pharynx. It will be tolerated at a lighter depth of anesthesia than will the older type of rubber airway. The nasal airway is an endotracheal tube cut to about 5 inches. This is transfixed by a safety pin to prevent it disappearing down the nose. It also is carefully lubricated before use. Other accessories include a gag, a swab holder, a bowl of gauze swabs, and a bottle containing liquid paraffin or castor oil to drop in the patient's eyes after the operation. Now for the patient. The most important points in preparation for an anesthetic are rest in bed for 24 hours where possible, no solid food for 4 hours, and nothing to drink for 2 hours beforehand. Purging is unnecessary and only weakens the patient. Morphine and atropine are injected 3/4 of an hour before the anesthesia is due to start. The morphine acts as a sedative, reducing the patient's mental anxiety and smoothing the course of anesthesia. Both the morphine and the atropine prevent excessive secretion of saliva and mucus, which might obstruct the airway. A suitable dose of morphine is 1/6 of a grain for a woman, 1/4 of a grain for a man. These quantities must be reduced if the patient is gravely ill or if he's over 60 years old. Too large a dose slows up the anesthesia by depressing the respiration. Of atropine, 1/100 of a grain is usually sufficient. Larger doses can be given, but they cause great discomfort. The time should be noted carefully on the chart. In 3/4 of an hour, the premedication will have taken effect. The patient will be ready for the anesthetic. Before starting, you must know all about your patient. Find out when she last had anything to eat or drink. If the operation is a hernia, ask which side it is. It may not be obvious when she's anesthetized. Make sure that the heart and lungs have been examined and the urine tested, and that the premedication ordered has in fact been given in the correct amount and at the right time. The more nervous the patient is, the more difficult the induction will be, and a few kindly words will help a great deal. Feel her pulse and try to reassure her. Tell her exactly what you're going to do and what is expected of her. Encourage her to relax and try to go to sleep. Examine her mouth to make sure that there are no loose teeth or dental plates that might become detached and cause obstruction. Also see that there is a clear airway through at least one nostril. Place the gamgee over the patient's face. Tell her it's to protect her face from the anesthetic. It also concentrates the ether vapor by ensuring that all the inhaled air comes through the mask. Make sure that her eyes are closed, or the gamgee might come in contact with them and lead to conjunctivitis, if nothing worse. Then place the mask in position. Always smell the ether before using it, unless you've just filled the bottle yourself. Drop the ether onto the mask, very slowly and cautiously at first, to allow the patient to become accustomed to the smell. Ether vapor is irritating to the larynx, and if it's given too rapidly at first, it'll make her swallow, cough, or hold her breath. If this happens, tilt the mask away until she's settled down, and then lower it gradually again. Provided the breathing is regular, the rate of flow should be progressively increased until you're pouring it on, but don't soak the mask. The chief guide during induction of anesthesia is the breathing. With loss of consciousness, it alters, becoming irregular, deeper, and often noisy. It'll usually take 10 minutes to reach the second stage of anesthesia. Don't look at the eyes, or you may disturb the patient if she's not quite off. But this is what they would look like. The pupils very variable, usually small, and the eyes roving from side to side with a divergent squint. To speed up the induction, place the jaconette over the mask. Under this, carbon dioxide will accumulate. Breathing will deepen, and the anesthetic will be taken in more rapidly. The jaw is not relaxed, and you can't put in an oral airway yet. If the breathing is not free, put the nasal tube down one nostril. As you saw, this is transfixed by a safety pin to prevent it disappearing down the nose. Speed up the flow of ether as fast as she will take it. Watch the breathing all the time. After another 5 minutes or so, there's a fairly sudden change to regular, so-called automatic breathing, which shows that she's down to the third stage of surgical anesthesia. You will find the eyes fixed and central with small pupils. The jaw is now relaxed, and the patient will tolerate an oral airway if you consider it necessary. As the jaw relaxes, the tongue falls back against the posterior pharyngeal wall and may obstruct the breathing. The artificial airway holds it forward, and proper support of the jaw will keep the breathing quite free. This is how you should hold the head, with the chin up and the jaw held forward by pressure behind the angles. You can keep your finger on the pulse in the facial artery where it crosses the lower jaw, or in the superficial temporal artery in the angle between the upper border of the zygoma and the ear. The patient is now ready for operation, but we'll continue and show what happens as anesthesia is deepened. Remember that as anesthesia progresses and the tissues become saturated, less and less ether is required to maintain a given depth. Listen always to the breathing. Any alteration in the automatic rhythm may be due to surgical stimuli in light anesthesia, or, as in this case, to a change in depth of anesthesia. The patient is now in deep surgical anesthesia, as might be needed for an upper abdominal operation. The pupils are larger. As anesthesia deepens, the intercostal muscles weaken and breathing is taken over more and more by the diaphragm. When they are fully paralyzed, the chest goes in instead of out as the diaphragm contracts, giving a seesaw effect. Provided the airway is quite clear, this is characteristic of deep anesthesia. This case shows it particularly well. Usually in the theatre, the anaesthetist must place his hand underneath the towels on the chest to be able to detect it. Ether, like any other anesthetic, is a poison, and the less you give, the better. The experienced anaesthetist will vary the depth of anesthesia to suit the various stages of an operation. For instance, this anaesthetist is lightening anesthesia during the performance of a gastroenterostomy. The eyes are now eccentric with small pupils, indicating light anesthesia. He deepens it again in time for the closure of the abdominal wall, allowing a good 5 minutes for this. The eyes are now central and fixed, indicating moderately deep anesthesia. And muscular relaxation appears to be adequate. However, for the beginner and the occasional anaesthetist, it's best to aim at maintaining a steady level of moderately deep anesthesia with central fixed eyes and small pupils. This will lead to less post-operative vomiting than too light an anesthesia, with its risks of laryngeal spasm and retching. These demonstrations may seem a comedy of errors, but such things do happen all too often. Here are some things you must not do to the conscious patient. The dropper hasn't been pushed in securely. If it had fallen out during the induction, the patient would have been considerably disturbed, and he would have lost the confidence you took such pains to establish. The anaesthetist persists in dropping ether too fast onto the mask, not noticing that the patient has started to swallow. He holds his breath and tries to take the mask away. Lift off the mask and reassure him. Never restrain a conscious patient. Lower the mask gradually and carry on with the ether, very cautiously at first. This patient is now in the second stage, unconscious but not fully anesthetized. Here is where most of your troubles will arise. Struggling at this point is not always avoidable. It's commoner in nervous patients and is often due to noisy surroundings. Attendants hold the patient down while you concentrate on keeping the mask over her face. One should lean across her knees while the other grips her arms above the elbows and presses them into her side. Keep dropping on the ether. When she is quiet, her limbs are straightened and her hands replaced by her side.